Pacemaker malfunction. Pacemaker malfunction can be classified as 1. Defects in pacing function. Abnormal pacing rates. Failure of output. Failure to capture. 2. Defects in sensing function. Over or sensing. Under or sensing. 3. Twiddler's syndrome. Approach to diagnosing pacemaker malfunction. ECG analysis. Pacemaker interrogation, pacing threshold, sensing threshold, lead impedances, battery voltage, magnet rate. Chest X-ray. Surgery is occasionally required for diagnosis. Abnormal pacing rates. Fast pacing rates in response to rate adaptive sensors or due to tracking of tachyarrhythmia up to the pacemaker upper rate. Pacemaker-associated arrhythmia, pacemaker-mediated tachycardia, sensor-induced tachycardia, runaway pacemaker, pacemaker-Wenckebach behavior, discussed earlier. Lead dislodgement arrhythmia. Pacemaker-mediated tachycardia, PMT. The pacemaker itself mediates tachycardia if ventricular activation, usually by a ventricular premature beat, is conducted retrograde to the atria, after the end of the post-ventricular atrial refractory period, PVARP. The resulting retrograde P-wave is sensed and tracked by the atrial channel, which activates a new atrioventricular interval, at the end of which ventricular activation occurs. If this ventricular activation is again conducted retrograde to the atria, the process can be repeated, and a tachycardia is created, in a way like reentrant tachycardias. The ECG clue to PMT is the presence of tachycardia in a patient with dual-chamber DDD pacemaker, with regular retrograde P waves following the QRS complexes. Pacemaker-mediated tachycardia is shown. Each ventricular spike results in QRS, followed by retrograde P wave. On the other hand, if the retrograde P wave reaches the atria during the PVARP, while the atrial channel is refractory, it will not induce a response, and no tachycardia occurs. Thus, prolongation of the PVARP in these patients usually terminates the PMT, and prevents its recurrence. Sensor-induced tachycardia. This tachycardia is induced by inappropriate pacemaker firing, due to abnormal response of the sensors to abnormal stimuli, such as vibrations, noises, movements, etc. The maximum pacing rate that can be reached in these cases is the upper rate limit. Tachycardia usually terminates with application of a magnet, that temporarily stops the pacemaker sensing. Runaway pacemaker. This malfunction of older generation pacemakers is related to low battery voltage, in which case there are two possibilities. 1. Tachycardia. The pacemaker delivers very rapid spikes at 2000 bpm, which may provoke ventricular fibrillation. 2. Bradycardia or even cardiac standstill, due to failure of the very rapid low-amplitude spikes to capture the heart. Application of a magnet can be life-saving, but definitive treatment requires replacement of the pacemaker pulse generator. Lead displacement arrhythmia. A dislodged pacing lead may float around inside the heart, intermittently tickling the myocardium and causing ectopic beats or runs of tachycardia, alternating with failure to capture. If the paced QRS morphology changes from left BBB pattern, indicating right ventricular placement, to right BBB pattern, indicating left ventricular placement, this suggests that the electrode has eroded through the ventricular septum. Failure of output. Failure of output occurs when a paced stimulus is not generated in a situation where expected. It may be intermittent or persistent. Causes. Oversensing is the commonest cause, but wire fracture, lead displacement, and battery depletion can also result in failure of output. Failure of ventricular output is seen. A pause showing native P waves without ventricular pacing spikes or QRS complexes. Failure to capture. Failure to capture is diagnosed if a visible pacing stimulus is seen, but no atrial or ventricular depolarization. It may be intermittent or persistent. Causes. 1. Increase in the pacing threshold above the pacing output is the commonest cause, either as part of the usual rise above the initial threshold within a few weeks following lead placement, or secondary to drug therapy, electrolytes, myocardial infarction, ischemia, etc. 2. Battery depletion, with decline of pacing output voltage. 3. Mechanical problems, lead fracture or dislodgement, insulation breaks. Ventricular failure to capture is shown. 3 ventricular pacing spikes are seen following the P waves, but not followed by QRS complexes. Oversensing. Generally, unipolar lead systems are more susceptible to oversensing. Ventricular oversensing occurs when electrical signals are inappropriately recognized as native cardiac activity, and pacing is inhibited. These inappropriate signals may be intracardiac, such as large P waves or T waves, extracardiac, such as skeletal muscle activity, or environmental, such as electromagnetic interference. Since ventricular sensing leads to inhibition of the ventricular channel, ventricular oversensing results in ventricular underpacing, while ventricular undersensing results in ventricular overpacing. Ventricular oversensing is seen as ECG pauses. T-wave or P-wave oversensing is regular, and can usually be eliminated by decreasing the sensitivity, that is, increasing the millivolts required to sense, or increasing the ventricular refractory period. Crosstalk inhibition is due to ventricular sensing of atrial output, a phenomenon that may be seen in unipolar pacers, but is currently a rare problem because of blanking periods and ventricular safety pacing. Electrode problems causing oversensing, such as fracture or insulation break, will usually be random and erratic. Ventricular oversensing with failure of output despite a slow intrinsic rate. Atrial oversensing. In dual-chamber pacemakers, atrial sensing inhibits the atrial channel, and starts a new AV interval, at the end of which triggering of ventricular pacing occurs. Consequently, atrial oversensing results in atrial underpacing, but ventricular overpacing. While atrial undersensing results in asynchronous atrial and ventricular pacing at the pacemaker lower rate. Atrial oversensing of myopotentials resulted in triggering of ventricular pacing at a rapid rate in the second half of the tracing. Undersensing. Undersensing occurs when the pacemaker fails to sense native cardiac activity. It results in asynchronous pacing. ECG findings may be variable, because not all pacing impulses can capture the atrium or the ventricle. Presence of pacing spikes within or immediately following the QRS complexes or the P waves, is suggestive of undersensing. Causes of undersensing. Intrinsic causes. 1. Changes in intracardiac signals, inadequate signals, or signals that fall within one of the programmed refractory periods. 2. Changes in cardiac tissue, inflammation or scar formation at the tissue-lead interface, infarction, ischemia, DC shock, etc. 3. Drugs, electrolyte abnormalities. 4. Pacemaker problems, lead fracture or insulation breaks, battery depletion or pacemaker generator reset causing asynchronous pacing. Ventricular undersensing resulting in 2 asynchronous ventricular pacing spikes, indicating that the pacemaker did not sense the preceding QRS complexes. Atrial undersensing. In this patient with AAI pacemaker, 3 P waves are followed by atrial pacing spikes indicating that the pacemaker did not sense the preceding P waves. Combined defects. Sometimes combined defects occur as demonstrated in this case. Undersensing of beat 2 causes early unnecessary ventricular pacing, beat 3, and oversensing after beat 3 causes failure of ventricular output despite the delayed appearance of the native rhythm, beats 4 and 5. Pseudo-malfunction. The following phenomena are considered pseudo-malfunction, not an actual pacemaker malfunction. Asynchronous pacing on magnet application. Fusion between the native and paced rhythm. If the pacemaker fires in time and an accidental simultaneous native impulse occurs, a fusion QRS of intermediate morphology is seen. Pseudo-fusion between the native and paced rhythm. If the pacemaker fires in time and an accidental simultaneous native impulse occurs but the QRS morphology of the native impulse is not affected by the pacing output. Twiddler's syndrome. This syndrome results from patient manipulation of the pulse generator. The pacemaker rotates on its long axis, resulting in dislodgement of pacing leads. This can result in diaphragmatic or brachial plexus pacing, depending on the extent of lead migration. Thank you.